I am Dr. Cristina Sanchez-Torres. I'm a psychiatrist, adult and child psychiatrist at Middlesex Health. I am currently the medical director for 3 services here, the consult service, the emergency room crisis intervention unit, and the interventional psychiatry services that include both ECT and esketamine services. Just a little background, born and raised in Puerto Rico, did my psychiatry training in Puerto Rico, came to Connecticut to do my training in child psychiatry at UConn. Worked at UConn for a full year doing outpatient and really realized that my passion is the inpatient world. So been at Middlesex for almost 8 years now, working on the inpatient side, both medical floors, emergency department, and again, the interventional psychiatry services. So I think that probably in 2020, I was asked by Dr. Podolsky to create and work on a grand rounds for you guys. And of course, we all know that COVID happened and then all of a sudden everything got postponed. So, and you'd think that by this time I would be a pro with Zoom, and I still have some difficulty sharing my screen, but I will do that right now. Feel free to interrupt me. I will look at questions if you post them on the message screen. Feel free to unmute yourself, interrupt me, ask questions as we go. I want this to be interactive, but if you have any particular case that you kind of think about that comes to mind, that we can save for the sort of last thoughts. So does anybody have any questions before we start? All right, so let's see if I can do this. Share screen. Okay. Nope, that's not what I want to do. See, you'd think that I'd be a pro. Slideshow. All right, so some of these things we're going to go over real quick. I think nothing like a real life sort of case to kind of understand things and put things into perspective, but I am part of the Academy of Consultation Leads in Psychiatry. I think most psychiatrists that work on the medical floor do get into this need to assess patients for capacity, which is of course the title of our presentation today, the assessment of decision-making capacity in adults. So this PowerPoint has a lot of adaptations from other psychiatrists that have worked on this topic before. So learning objectives, we are going to talk about the process of obtaining informed consent for medical and surgical procedures. We're going to define the terms competence and capacity. Those are usually used interchangeably, but one is a legal term, the other is a medical term, a clinical term. We're going to learn what's involved when you assess capacity and the four core components of the model of capacity assessment. Talk about relevant questions to ask the consultees and the patients in a capacity evaluation. Talk about a little bit about power of attorneys, conservatorship, substitute decision makers in medical and surgical cases, and we have a case that I will probably talk about as we go through, not leave to the end. We basically, when we assess somebody for capacity, we're going to try to help to decide if the patient has a clarity of mind to agree or to refuse a treatment or procedure. And like I said, it's one of the most common reasons for a psychiatry consultation on the medical floors. So we'll clarify key points in the determination of capacity. So I think there's usually a misconception that only psychiatrists can assess capacity, but capacity is part of the informed consent. It's the third element of informed consent, which means that any physician on a daily basis, any nurse practitioner, physician assistant in the emergency department, on a daily basis when they have a patient in the emergency department, on their offices, they should be assessing capacity for the patients to make certain decisions regarding their medications and any procedures that are being recommended. The important thing to note, and I think this is also a common misconception, and when I started here at the hospital, I used to get called with the question, is the patient able to make all of their medical decisions? And It's a sophisticated clinical assessment of an individual's global and specific cognitive abilities within a particular context. So what that means is that somebody may be able to understand well what a colonoscopy is and why they need a colonoscopy, but not a lumbar puncture. So there is no such thing as assessing somebody's capacity to make all of their medical decisions, right? Because we all understand things very differently. I'm terrible in math, but I'm great in history, right? So my cognitive abilities to retain certain information and understand certain information changes depending on the context. So of course, elements of the informed consent, you have to disclose the information that is important for the patient. You have to make sure that it's a voluntary choice. And then the third element of informed consent is capacity. And like I said, every physician on a daily basis, whether they notices or not, when they make a recommendation for medication, you want to make sure the patient understands how they're taking it, why they are taking it, what the alternatives are, how things would look like if they take the medication, if they don't take it, right? So every physician on a daily basis with every clinical encounter with a patient should be assessing capacity. So a little bit of history prior to all of this informed consent. Objection to treatment was usually respected by staff, but the consent was often inferred or revoked by incomplete or misleading information. So late in the 60s, early 70s was when all of this whole capacity assessment sort of comes to mind. And the goal is to, of course, allow an individual with decision-making capacity to exercise effective and informed self-decision-making to retain some autonomy over their treatment. Like I said, purpose of informed consent to promote individual autonomy, to foster rational decision-making. And it's founded on two distinct legal principles, which is the right of self-determination and the physician's fiduciary responsibility to the patient. So what are we going to be disclosing when we are talking to patients about a treatment that we are recommending or a procedure? We're going to talk about what the diagnosis is, the nature of the condition being treated, what are the expected benefits of what you're proposing for the treatment to be, the nature and the likelihood of the risks that are involved, the inability to precisely predict the results of a proposed treatment, the expected risk, benefits, results of an alternative, or no treatment at all. And the important thing is that there's both the professional standard and the reasonable patient standard. So professional standard is what anybody in a reasonable member of the profession, so what any psychiatrist in my case would be discussing with a patient in a similar situation. And the reasonable patient standard is what would be important for the patient to know, would find material when the patient is making a decision. We have to make sure that the patient is voluntarily making this decision, right? That no coercion is being used. And I don't think I have to say this, but coercion by any medical professional is unethical. And of course, it's going to take into account that it's going to take, the patient's ability to act in accord to what is right for them in light of their situation, their values, their history. So like I mentioned at the beginning, capacity is a clinical decision, right? And it's the ability to accept or refuse treatment recommendations. And like I said, it's a medical clinical concept. Like I mentioned, it does not have to be performed by a psychiatrist. It's at times perfectly reasonable or helpful to get a second opinion from psychiatry, particularly when you have patients that might be delirious, that
Here's what I found.
You are unsure if there is an active psychiatric illness or decompensation that would be getting in the way of the patient making a decision. And of course, I think that in many places, patients with a psychiatric diagnosis, a dementia diagnosis might be seen as patients who do not have capacity, but capacity has to be presumed for all of these patients because patients, even when they do have a psychiatric illness and they are very sick, even dementia patients who are very much progressed in their dementia process may still retain capacity to make certain decisions, not all of them, but certain decisions. So competency, like I said, it's a legal concept formally determined in a court of law. The judge does rely on clinicians' recommendations It is usually considered to be more of forensic evaluation, and competency. I'm sure that maybe when you're hearing the news, when you're watching the news, and there's a lot of these very famous cases, and you hear on TV, the patient is incompetent to stand trial. So being incompetent to stand trial essentially means that you aren't able to sort of assist on your own defense. And there's some various reasons as to why that could happen. But in our world, right, if somebody is struggling with an acute psychotic break, the patient might not be able to engage in their own defense. So that's when patients are found incompetent to stand trial, for example. So lack of capacity attributes a status unto the individual that is defined by having some deficits judged to be sufficiently great that the person currently cannot meet the demands of a specific decision-making situation and its consequences. So a couple of important points, and this is where I like to kind of pause and spend a little more time in. Like I said, it's determined on a situation-by-situation basis. Patients can have capacity to make some decisions, but not all of them. So you have to clarify the question, the specific capacity question. So for example, if you want to call and say, does the patient have the capacity to refuse, say, dialysis, right? So it's a very particular, specific question. So one important thing is that I'm going to move forward and show you the 4 components of capacity. So the 4 components or core abilities include that the patient has to be able to communicate a consistent choice. It could be a written one, patient could type it, patient could text it to somebody, as long as it's a choice and it's consistent. The patient has to demonstrate that they can understand relevant information about their treatment, about the nature of their condition. The patient has to demonstrate that they can appreciate the circumstances of consequences, again, of treatment, no treatment, procedure, no procedure, alternatives, and that the patient is rationally manipulating the information. So when you think about those, and we talk about a sliding scale, when assessing capacity in an attempt to honor patients' autonomy while still doing no harm. And so say that you have a patient that may have capacity to refuse phlebotomy. And when you think about a phlebotomy, somebody drawing blood in a patient, it's a low risk procedure. And sometimes you have to think if the risk to benefit ratio is low of saying that the patient doesn't have capacity to refuse a lab draw. So I like to use the example of, say that you have a 90-year-old gentleman who comes to the hospital because their sodium was low. And the patient got a little bit confused, got a little bit agitated at home, and patient has been at the hospital for 3-4 days. Patient's sodium has been going up, and the patient has daily lab draws to make sure that the sodium is going up. And on day 4, the patient is saying, I don't want it. It's bruising me, it hurts me every time that you draw my blood, and I don't want it. And you have a family member that's saying, he looks a lot better, he's more himself, he's not aggressive, he's not agitated, he's not combative, I'm glad to hear that he's doing well. And you have 3 days worth of knowing that the sodium is going up. If I were to assess capacity on this patient, right, 90-year-old, the likelihood that he doesn't know why he's in the hospital is high, right? The likelihood that he will understand why labs have to be drawn every day, that he will understand that, the likelihood is very low, right? The likelihood that he understands what the alternatives are is very low. So when you think about what the risk would be of saying he doesn't have capacity to refuse a lab draw, so you now probably will create a different set of problems, right? Because he probably, if you want to call the next of kin and say, we need to draw some blood, you will probably have to restrain the patient, right? So now you're creating a whole set of different problems for a procedure that likely is not really to be of great benefit for the patient at that time, because you have clinical information that lets you know that the patient is doing well. and you have objective evidence with labs, previous labs, that the patient is improving. So those are the sliding scales that we use. The patient is saying, it's hurting me, it's bruising me. It's okay for us to say, we're going to either try it later or we're not going to do it, rather than the knee-jerk reaction sometimes that a lot of places have to say, oh, we need to call psych because the patient is refusing something, right? Without kind of sitting back and kind of considering the sliding scale of, if we are really going to say that he can't refuse the phlebotomy, or if we're going to just kind of either try it later or use the sliding scale and say, it's okay to not do it for now, right? Versus if somebody needs an urgent cardiac surgery, that's the time where a sliding scale should not be used, and you should have more stringent criteria when you're assessing the patient, which a cardiac surgery is a high risk surgery. But if somebody needs it urgently, or somebody needs it, you should make sure that the patient is understanding all 4 components, and that the patient is demonstrating all 4 components of the capacity assessment. Capacity can change over time. And capacity, again, refers to a specific condition and a current situation. It's not an enduring status. So say, for example, that I see a patient for refusal of a colonoscopy, and I say the patient has capacity to refuse a colonoscopy. If the patient were to come back 5 years from now and need a colonoscopy, and the patient says, I don't want it, there is no validity to my assessment from 3, 4, 5 years ago. Patient needs a new capacity assessment. There's a lot that can happen in 5 years. And again, it's not an enduring status. Somebody not having capacity to refuse a colonoscopy today doesn't mean that they would not have capacity for 5 years from now. So the other aspect of this is that I once was asked if the patient can consent for surgery 2 weeks from now on a patient that I was consulted on. Patient had some depression, but needed an amputation 2, 3, 4 weeks from the day that I was assessing the patient. And that's a what if assessment, right? I always say there's so much that can happen in 2 weeks from now, 3 weeks from now, 4 weeks from now. God forbid, say the patient goes home and the patient, God forbid again, unfortunately gets into a car accident and develops a traumatic brain injury. So the capacity assessment would have to be made, the day of surgery or the day before, when surgeons usually get the consent, a few days prior to surgery. So it's not something that can be done like today for something that's going to happen a few months from now, a few weeks from now. So it's a current situation, right? Specific condition and current situation. So important to remember that to make sure that there are no communication barriers impairing the patient's ability to understand the information, right? So you want to make sure the patient, if they need hearing aids, if they need glasses to read anything that you are giving them in writing, that there's no difficulty with the patient talking or expressing himself. And of course, I think sometimes we forget that not everybody understands medical jargon, and that's when we really need to digest what we're discussing with the patient to a more sort of basic and understandable communication and what we're saying. So this is a chart that I like to add to my consults. And when you think about assessing capacity, evaluating capacity, you're going to want to think about treatment risk and treatment benefits. And if you think about it, if you think about somebody refusing a treatment whose risk is low and the benefit is high, why would the patient refuse something that is highly beneficial and low risk? It would not make sense for somebody to refuse a treatment like that or a procedure like that, right? So if you have somebody who is refusing, right, that's the reason why I get consulted the most, refusing treatment. And then we'll talk a little bit about when the patients consent. But if you have a patient that is refusing a treatment or a procedure, and you think that the treatment risk is very low, right, but the treatment benefit is high threshold for capacity, which means that you're going to lean towards deeming the patient incapable of making that decision because it just simply does not make sense, right? If you have a FDA approved treatment for a patient and the risk is low and the benefit is high, it makes no sense that anybody would refuse that. So, and alternatively, I always say, right, that there's a few things that come up with when the patients consent. Right, say that nobody should be encountering this situation, but say that I as a surgeon, right, go and I see a patient and I say, hey, you need an appendectomy. And then, you know, I assess the patient. And when I'm looking at the patient, I say, you know what? We're going to go in for your appendectomy, but I kind of don't like your left arm. Why don't we just kind of take it off, you know, while we're in surgery? You're under anesthesia. Well, I just don't like your left arm. And the patient goes, sure, I'm right-handed. Who needs a left arm, right? So imagine a treatment risk, right? Treatment risk would be super high. There's nothing wrong with the patient's left arm, right? And the benefit would be so low, right? So why would anybody consent to something that is very risky and of low benefit? So you have to kind of ponder the question, why would patients say yes to something so risky with low benefit, right? So that's when you kind of go to the chart and you say, okay, so high threshold for capacity, we're going to lean towards deeming the patient incapable of making decisions, right? So alternatively, I did have a patient who consented, this was a young man who consented to an injectable medication for a gastrointestinal condition that he had. And the gastroenterologist felt like the patient consented too quickly. And so they called and they said, oh, we're not sure that he understood everything. And this gentleman had some intellectual disability, but still very much able to converse and understand a lot of his treatment. He understood everything that was going on with his gastrointestinal condition. He consented. I asked him and I said, you know, why are you consenting to an injection? Some people don't like injections. And he very matter of fact, you know, it's unfortunately a gastrointestinal condition where the patients bleed, have lower bleed. So he very matter of fact looked at me and he said, Miss, I don't want to bleed for my behind, right? So it was a very concrete matter of fact answer, but it made perfect sense. He said, I don't have to take a pill every day. This is an injection every month and I don't want to bleed. So he was concrete, very matter of fact. Maybe he didn't say something that maybe another person would have said, you know, such as, I have a friend who works in an endoscopy setting and he says that this is the best treatment. Sent me an article, I read it, I think it's the best treatment for me. But he very much matter of fact said, I don't want to do this. The alternative is pills and I don't want to take pills every day. So I'd rather take an injection, you know, that will not make me bleed. So he consented to a treatment risk that is very low, right? And the benefit is high, right? So you would come here and you would say, so I'm going to lean towards deeming the patient capable of making the decision because it makes sense, right? Is a high benefit, low risk treatment. So it would make sense for somebody to consent for that. All right. So who should assess capacity and what information is needed? So I always say, treating physician, right? The treating person who is making the recommendation is often the best choice, is the person who knows ins and outs of the medication, ins and outs of the procedure. And again, consulting psychiatry may make sense in difficult cases when there's a high risk of reaching a faulty conclusion. And some of the questions that we need to be asking is, why is a consult being requested? Why, and I asked the primary team, usually, why do you think the patient may lack capacity? What is the patient's medical condition? What are the other choices? What are the risks and benefits of these choices, right? If it's I'm the first person sort of interacting with the patient in terms of a capacity assessment, and what has already been communicated to the patient. And again, like I said, a specific decision, right? It cannot be, should not be all medical decisions, right? It has to be a particular specific decision. So we talked about the four core components or four abilities: the communicating or consistent choice, understanding relevant information, appreciating circumstances and consequences, rationally manipulating the information. So one thing that I always talk about, I'm going to be referring to this part over here, where the courts have recognized that patients who do not acknowledge their illness, right, often referred to as lack of insight, cannot make valid decisions about treatment. So the reason why I bring this up is because I had a case where this older gentleman, living in his car, so driving around town on a daily basis, he unfortunately had a seizure and he crashed his car. He was okay. He didn't hurt anybody, but he comes to the hospital. They do work him up. They find out that he has epilepsy. He has a seizure disorder. And they recommended some medication. And of course, he started to refuse it. So they call me because he's refusing his anti-epileptic medication. Of course, are concerned that this is a patient who lives on his car. He drives around town. What if he has another seizure, crashes his car, kills himself, hurts somebody else? So when I go see this patient, his rationale was that he was in his late 70s and that he had never had a seizure before. So why would he have one at 78? He even said, you know, if my mom was alive, she could tell you that I've never had a seizure in my life. So why would I have one now in my late 70s? Right. There was nothing that we could say to him. There was evidence in electroencephalograms, EEGs of seizure activity. And there was nothing that I could explain to him that would make him believe or acknowledge that he does have epilepsy. So this is a patient that I made a recommendation to have a conservator appointed. This is somebody who simply had chosen to live in his car for as many years as he had, but he had a steady income. He just decided not to have a location, a home. So, and I did not recommend a conservatorship because I wanted the conservator to go to his house and shove a pill down his throat, right? But the rationale behind it is that if this patient gets somebody who can manage his money and perhaps, you know, go to DMV and he can't have a license anymore, take his car keys away, ensure that he has a safe place to live, because he was a danger to himself and to others if he were to be released to his car, where he was going to be driving around town all day, living in his car without a condition being treated. So legal issues, because of legal issues regarding licensing, this assessment is not appropriate job for nurses, nursing assistants, technicians, or other support staff. Like I said, psychiatrists are often felt to be the experts of this assessment, and they can be involved in complex situations. Like I mentioned, in the emergency department, a rapid assessment of capacity is usually needed. And any licensed physician, assistant, or nurse practitioner can and should be able to assess and determine capacity in these situations. Foundation of the assessment is a mental status examination, which I'm sure a lot of you are familiar with. We are not going to go through the mental status examination. I'm happy to share this with everybody, but it's based on all of these 12 components. So usual questions that you want to engage the patient in when you're trying to see if the patient has an ability to understand, right? So basic questions like, why are you in the hospital? What are the doctors saying? What could happen to you if you don't do what the doctors would want you to do, or the recommendations, right? You're trying to understand if the patient understands their diagnosis, what could happen to them, what are the treatment options, and the risk and benefits of treatment. Ability to appreciate the circumstances, right? Related to the patient's ability to apply the information that he or she knows about his condition and the treatment recommendations to his or her own situation, right? And it should focus on the patient's beliefs, right? More than the knowledge. You've already trying to understand that on the first component. What are the belief of the illnesses, the belief of treatments, and suggested questions. What do you believe is wrong with you? Do you think you need some type of treatment or intervention? And what do you believe will happen to you if you don't get treated? Ability to reason, right? Does the patient use the information that you've given to them, that you've discussed with them, to engage in a rational process for the of options? Is there a reasonable reason for the patient's choice, right? And you can ask the patient, tell me what kind of things did you think about when you reached this decision? You know, how did you weigh the information that was provided for you? I usually like to ask patients, do you know of anybody that has had this treatment before, right? Because then they'll get into, oh, my neighbor, and he died on the operating table, right? And they're just not, they're going with what happened, the outcome, right? Without taking into account that that patient's unfortunate circumstances might have been different than theirs, right? And it's important to know all that, the beliefs, how scared the patient is about the treatment or procedure. So again, summary of the abilities: expressing a consistent choice, understanding, appreciation, and reasoning. So one, I think the case that we have at the end, but I like to kind of talk about it when we talk about the functional abilities and 4 components. So I had this patient who, a female, mid-aged, well-educated woman who came into the emergency room with a gastrointestinal bleed. And she had a little bit of altered mental status. They had recommended an endoscopy and a colonoscopy for her. And she agreed to the endoscopy, but she refused the colonoscopy. So in that case, they did call me and said, does she have capacity to refuse her colonoscopy? So when I go see this woman, she said, I'm at the hospital because I had a gastrointestinal bleed. I was a little confused, but I received some transfusion. I'm feeling better. I'm not bleeding anymore. And she said, you know, I have to see a gastroenterologist more often because of some family history. And I actually have an appointment to get a colonoscopy in 3 months. And I'd much rather have it done by my gastroenterologist, who I trust, I've been seeing forever. And she said, you know, I can call him and let him know that I was in the hospital and see if he could do it, you know, sooner rather than later. And she said, you know, I live by myself, but I was able to call the ambulance. If this happens again, if I bleed again, I will call the ambulance. I'll call my neighbor who, you know, kind of came with me to the emergency department, and I'll just come back to the hospital. So she was clearly expressing a choice, right? She was able to demonstrate that she was able to comprehend the information that was provided. She was given the opportunity to do a colonoscopy. She knew that the alternative was to not do the colonoscopy. She knew what was going on with her, what had transpired, what had been done. She had received a transfusion. She was able to say, I'm not bleeding anymore. And she said, I prefer to do it with my gastroenterologist, right? None, and no way, shape, or form did she say to me, you know, the little blue alien that sat at the end of my bed last night told me not to do it, you know, or I think they're going to try to, you know, put something in me through the colonoscopy. There was no evidence of any thought disorder or there was a reasonable reason for her declining of the colonoscopy. So she had clear capacity to refuse the colonoscopy. And unfortunately, a few days later, she develops altered mental status again. I think she had some hallucinations. Neurology gets involved. They order a certain set of workup, including MRI, lumbar puncture. And she agreed to the MRI, but she did not want the lumbar puncture. Now, for those of you who are unfamiliar, lumbar puncture is a sort of considered very low risk procedure with a high benefit, right? There's no other way of obtaining CSF with this, which is precious fluid that is in the spinal cord and in the brain, to determine if there's any infection going on or something else that might be going on in her brain that cannot be detected otherwise. So when I go in and I said to her, you know, what is going on? She kept repeating, you know, I just need to go home, take some Tylenol. Yeah, I have a headache. You know, I'll take some Tylenol. I'll sleep it off. I'll be fine. Nothing's going to happen. You know, I just need to go home. I'll take Tylenol and nothing's going to happen. So I explained to her, I said, you know, what if there's something really wrong in your brain? And the only way to treat it is with intravenous medications, and you have to be in the hospital to be monitored for that. Said, nope, there's nothing going on. This has happened before. it's just a Tylenol. I need to sleep it off. I'll wake up with a headache. I'll be fine. Nothing's going to happen. So unfortunately, she was refusing a procedure which is low risk with high benefit, right? So it wouldn't make sense for her to refuse such an important procedure to try to determine if there was something going on in her brain. So I had to say that she did not have capacity to refuse the lumbar puncture. But imagine if when I saw her initially for the colonoscopy, if I had said she has capacity to make all her medical decisions, when it was super clear that she had capacity to refuse the colonoscopy, but not the lumbar puncture. She wasn't understanding the sensitivity, the urgency of trying to figure out what was going on with her and her altered mental status. So that's why I always emphasize that it is a current situation, a specific question. It cannot and should not be all medical decisions. All right, so we went through that. There are some validated instruments to assess capacity. The advantage of them is that it's a little more structured interview with good inter-rater reliability. They're not really used in routine care. They might be useful in complicated cases, those where there's a lot of disagreement about among various parties, or cases that are likely to be reviewed in court. Some of these are free in the public domain. We're not going to go through them because, again, they're not really used in routine care, but I wanted to make sure that you were aware that there are some validated instruments. So when should decision-making capacity be assessed, right? As I mentioned before, in every encounter, it is often done, but unrecognized, not really noting that you're doing it. When there's abrupt changes in mental status, when patients refuse treatment recommendations, including, again, leaving against medical advice, right? And that might be a little bit more complicated, I always say, because there might be various reasons why the patient is in the hospital and the patient just wants to leave against medical advice. For those patients, I will usually tell the physician, I'll say, which out of everything that you're treating, if you send this patient home against medical advice, will not let you sleep at night. For a lot of patients that I see here, it's usually patients that are going through alcohol withdrawal. There are sometimes patients that want to leave against medical advice and all they need is a chat. There was a patient, most patients end up staying. And I always say, that speaking to patients is not really overrated. A lot of patients just need to vent their frustrations, their concerns, how scared they are. Some patients do have a lot of responsibilities outside in the community and they don't want to miss work. They don't want to miss court. And sometimes just kind of talking to them and explaining certain things might be helpful. I did have a patient who was here for alcohol withdrawal. And he got very angry, very belligerent, unfortunately. A lot of staff got really scared. And I come in and I just simply asked, why do you want to leave against medical advice? And he said, I have court today and I don't want to miss it at 1 p.m. And I said, oh, that's very simple. The social worker can send a letter to court and you are in the hospital. They would have to postpone it or, excuse you from it. And then he said, oh, okay, then I'll stay, right? So it was simple chat. Why do you want to leave against medical advice, right? I think that sometimes the approach that some providers will take will be like, well, you can't leave against medical advice. And I think that anybody here that has children or nieces or nephews know how the word no goes, right? Versus if you change it, like what is going on that we can maybe help you with so that you don't have to leave against medical advice instead of saying you can't leave, right? Because patients will say, well, let me show you how I can leave. And they'll rip their IVs, they'll walk out, there'll be chaos. Again, we talked about risky treatments such as cardiac surgery, right? Important to make sure that you're assessing capacity. And when patients have a risk factor for the impaired decision-making, such as dementia and delirium. And like I said, having dementia, having delirium does not automatically mean that you don't have capacity to make decisions. You may make certain decisions, but not others. Careful documentation is always important. I think that everybody knows this. I don't think we have to talk too much about this. Important documentation. the way that I was trained was if you don't document it, it never happened. So important documentation, right? And unfortunately, we are living in the world where we have to document, like our worst enemy is going to read the chart. And if you don't document it, it didn't happen. So important to keep careful documentation of what was discussed, that you answered all the questions to the patient, that you allowed the patient to ask questions. And of course, you want to document if the case is that you find that there are psychological factors, psychiatric diagnoses, or neurocognitive disorders that are impairing or diminishing capacity. You want to document what kind of interventions you would recommend to make sure that the patient regains capacity. Let's see. We talked about this. If the patient is incapacitated, what is he incapacitated by, right? And like I said, important to document and recommend treating the illness in hope of restoring capacity. So in terms of substitute decision making, once a patient is deemed to lack capacity, you need a substitute decision maker. I think the knee-jerk reaction sometimes at places is to say, well, does this patient need to be conserved, right? And there are some recommendations to when you should consider having a power of attorney or a conservatorship appointed. I always say, if you, for example, there's no substitute decision maker. It's somebody who is alone. Every family member has passed, never married, no children, no niece. Maybe the next of kin is in Australia and this person doesn't really feel up to making decisions for this patient because I haven't talked to her in 10 years. I don't know her very well. I don't know what she would want. I don't feel comfortable, right? Perfectly reasonable to consider guardianship or conservatorship when the capacity is not likely to be restored in the near future. So when that happens, it's usually when you have a patient who has been recently diagnosed with dementia. And we all know that it's a progressive disease. So it's unlikely that capacity is going to be restored. If there's a decision that needs to be made, particularly of ongoing treatment with any procedures, interventions, or medications, it's reasonable to consider a conservatorship. And again, like I said, when there's ongoing medical decisions that will likely need to be made. So options for substitute decision making, there's advanced directives like a living will, where the patient is documenting their choice of treatment under specific circumstances. The power of attorney or healthcare proxy. Patients may designate persons to make decisions for them when they are incapacitated. And then if there's no advance directive, usually families are asked to make decisions, right? You kind of go through the next of kin. And in Connecticut, it's this priority that I placed over here. So the spouse of patient, if the patient is not married, never been married, an adult son or daughter, if no children, either parent of the patient. If they are deceased, and you go through an adult brother or sister or grandparent. So decision makers through the court is usually a last resort, right? We try to find, again, a next of kin when a patient is in the hospital that could make decisions for that patient. Patients can challenge the findings of incapacity in court or the conservatorship and guardianship. It's just a process that it includes, having a hearing. The patient will be appointed an attorney. And then patients can be assigned a conservator of person and a conservator of this estate. So if person is responsible for decisions about care provisions and living arrangements, and estate, it's more for financial and properties, regarding properties. So many capacity consults are not about capacity at all, but rather of ethical dilemmas. I think that a lot of times providers find themselves kind of questioning, why the patient is refusing a certain treatment, right? When it's not something that I would do or the provider. But I think the important thing is that we need to remember that patients are allowed to make bad decisions, right? Decisions that we may not agree with, but as long as you assess capacity and they do have capacity, patients are allowed to make bad decisions. And I think this is the part where it gets into an ethical dilemma sometimes in the hospital. So our role is to kind of elucidate that real issue, and sort of be sort of a collaborative sort of intermediary between the patient and the team. And again, if we suspect that there's a psychiatric illness, to determine if there's an acute process that could affect the decision-making capacity of the patient. And to, again, recommend interventions, medications, anything that might be helpful for the patient to regain capacity. And like I said, in more complex cases, provide a second opinion. So points to remember: global capacity assessment or an assessment of the patient to make all of their decisions is not considered an appropriate evaluation to make. Any licensed physician, physician assistant, nurse practitioner can assess a patient's decision-making capacity. It begins with the presumption that person has adequate capacity to make decisions. And again, like I said, patients are allowed to make bad decisions, right? Decisions you might not be in agreement with, and they can still be judged as capable of making that decision. And when in doubt, again, there's never anything wrong with asking psychiatry team for assistance. So this is a patient that we discussed with the gastrointestinal bleed that refused the colonoscopy. And then we asked about the lumbar puncture. She did not have capacity to refuse the lumbar puncture. And again, like I said, lumbar puncture, relatively low risk intervention with a very high benefit. So you would deem the patient likely incapable of making that decision. All right, so some of my references, I'm happy to share this presentation with anybody that wants it. I can send it to Darcy. Just if you use it, please quote me in the American Academy of Consultation and Liaison Psychiatry. Thank you for your time. We do have a lot of time left, so I don't know, I'm gonna close this and get back to all of you. And let's see. And if anybody has any questions, feel free to unmute yourself. Let me see if I can. Are you still seeing my? Hang on. I can't even believe that I am this. Hang on.
I have a question.
Yes.
Is there any way that can the patient be reevaluated 30 days after the surgery if they had a colonoscopy? So patient went in, had a colposcopy, and they were deemed incompetent. So the request was made 30 days after the surgery, can the patient be reassessed with his PCP? It was initially answered yes. However, rather than being able to go back to the PCP, patient went back to nursing home, and the PCP and the nursing home facility has two different physicians, and they're not communicating with each other. So how do you go about that?
So was there a need still for a colonoscopy after those 30 days?
No, the surgery was a success. Patient survived the surgery. What appeared to be the blood loss was returning. Patient was regaining competency, and however, the communication between the normal PCP and the nursing home, they're not communicating with each other. So how do you go about that?
So the one thing is, right, so if after 30 days the surgery was a success and there was no need for the colonoscopy, at that point there would be no need to assess capacity for the patient to refuse the colonoscopy, right? So I always say, if what is a question right now, right? Because if there's no need for colonoscopy, why would you be assessing at this point, right? If there should be a need for a colonoscopy, then at that point. But if the surgery was a success, right? And there's no need for colonoscopy, there would be no need to assess for capacity, only if it comes up again, right?
Got it.
Because say that the patient doesn't need a colonoscopy in 5 years, right? And like I said, God forbid, in those 5 years, the patient has a stroke and develops some deficits, memory deficits, right? So assessing 30 days after, if there's no need for a colonoscopy, is not going to give you any valuable information because you don't need a colonoscopy right now.
So
Right.
that's why there's no need to be reassessed.
Correct, right.
Got it. Okay,
Yep.
thank you, Doc.
Yeah, no problem.
Yeah.
Anybody else has any other questions, comments, concerns, critics, open to constructive feedback? No?
I just have a comment. My name is Amanda. I just think this was, I also left a comment in the little chat box, but I think this is so interesting, you know, coming from a social work perspective of, you know, obviously we're harm reduction here. And I think there's just like a lot of parallels with, you know, what you guys do in the hospital setting. And I think it's a really good reminder that we all want the same things for our patients. And that I think sometimes when we have, you know, us here at the clinic, there's a lot of communication that happens between our nursing staff and local hospitals when we share patients. I think it's just a really good reminder for us that we all want the same things for our patients, and that what you're doing in the hospital setting, you know, meeting the patient where they're at, you know, not forcing them to do things unless it's, you know, absolutely, you know, following that kind of hierarchy. It's very similar to what we do in social work and meeting the patient where they're at. And so I think it's really nice to see those parallels in other professions or other settings. And I think it's a good reminder to us that we're all wanting the same things for our patients. And so thank you so much for this information. It was very, very informative.
Thank you. Absolutely. Thank you for the feedback. I agree. I think it's good to note that we all want what's right for the patient, right? While also addressing their concerns, meeting them where they're at, and ensuring that we are keeping them safe and reducing the harm, mitigating the risks, right? I think that sometimes, and you know, I think sometimes in the hospital, it's interesting because case managers will say, you know, the patient is refusing to go to short-term rehab, right? And they want to go home. And then I go assess the patient and I say, well, she doesn't really have capacity to refuse short-term rehab, but is there an alternative, right? And then half of the times, the case manager will say, well, insurance will pay for, you know, rehab at home. And then I'm like, well, then where are we, you know, you know, like, let's try to meet the patient where they're at. I mean, I would want to go home. I would probably be a terrible patient. I would probably refuse a lot of things, you know. I want to go home after 15 days in the hospital. I don't want to go to short-term rehab, you know, and if the insurance is paying for the short-term rehab to be done at home, then what are we doing, right? Let's do what's right for the patient. Insurance is covering it. Why are we engaging in this back and forth, right? Anybody else? Any other questions? Any other comments? I will definitely share my presentation with Darcy, and if anybody wants access to it, you can ask Darcy.
Can you send me one too?
Yes. Yes, I will. If Darcy, Darcy, will you share it with him, with Daniel? Oh, we can't hear you.
Yes, I will
Okay.
definitely share.
Perfect. So then whoever wants it can maybe email Darcy and she can forward it to you. Well, it's been a pleasure to have you all. I didn't get to see all your faces, but thank you for joining and for listening and paying attention. I know it's lunchtime, so I appreciate your attendance. And if anybody wants my contact, I'm always happy to discuss cases or anything that may come up that you may need help with. So you can ask Darcy for my email and feel free to reach out.
Thank you so much.
Absolutely. Well, have a good rest of your day, everybody.